Hello and welcome to the BSAVA Science webinar, taking a closer look at some of the papers published in the Journal of Small Animal Practice. I'm Luisa Dormer, Scientific Editor at the BSAVA, and today I'm joined by Nicola Di Girolamo and Charlotte Howes to discuss the paper, Long-Term Clinical Outcomes Following Surgery for Spontaneous Pneumothorax Caused by Pulmonary Blebs and Bullae in Dogs, a multi-centre Association of Veterinary Soft Tissue Surgeons Research Cooperative retrospective study. This is the winning paper of the BSAVA Melton Award 2021. The Melton Award is presented to the first named author of the best original research article in small animal surgery, published in the Journal of Small Animal Practice during the 12 months ending 30th of September 2020. The recipient of the award is nominated and selected by the Journal of Small Animal Practice editorial board in recognition of their outstanding contributions in the field of small animal veterinary medicine. The recipient of the award is Charlotte Howes, a resident in small animal surgery at Langford Vets, Bristol. Nicola is an associate professor in the Department of Veterinary Clinical Sciences at Oklahoma State University and is the editor-in-chief of the Journal of Small Animal Practice. Welcome to both of you.
Hello.
So Charlotte, firstly, a huge congratulations on winning BSAVA's Melton Award 2021. Before we start discussing the research in more detail, please could you just recap what pulmonary blebs and bullae are and how they are associated with the spontaneous pneumothorax?
Thank you. It's a great honour to receive this award and also to speak to you both today about our research. So to answer the first question that you had, which is what are pulmonary blebs and bullae, I think it's important to first consider the normal anatomy of the lung. So we have the lung parenchyma, and then we have two layers of visceral pleura that cover the lung parenchyma. And these two layers are the internal and external elastic layers. And pulmonary blebs essentially form between these two layers of visceral pleura. And these are most commonly found at the lung apices, and they often appear like blister-like lesions. In contrast, we have pulmonary bullae, which are more air-filled structures that actually occur within the lung parenchyma itself. And there's three different types of pulmonary bullae, so 1, 2, and 3, and these depend on the degree of destruction, dilatation, and confluence of the adjacent alveoli. So pulmonary bullae can vary quite a lot in their appearance. They can be quite small focal lesions, but sometimes they can be quite extensive and they can affect the whole lung lobe that's affected. And so in answer to your next question, which is how are they related to spontaneous pneumothorax? Well, firstly, with spontaneous pneumothorax, we define that as a pneumothorax that occurs in the absence of a trauma. And we have primary and secondary spontaneous pneumothorax, with primary being in the absence of an underlying pulmonary pathology, whereas secondary being where we have an underlying pathology, for example, a pulmonary neoplasm or an abscess or pneumonia or a tracking foreign body. So what I find is really interesting in these cases is that it's not uncommon that we'll find a dog that goes through a CT scanner where we'll find an incidental pulmonary bleb or bullae. It's also not uncommon that we'll be in theatre and we'll find multiple blebs or bullae, but some of those don't always leak when we do our saline submersion test. So this leads us to believe that there are a subset of dogs that have these pulmonary blebs and bullae, and some of those go on to rupture, which then causes a connection between the pulmonary parenchyma and the thoracic cavity that then leads to the pneumothorax. So my mentor, Dr. Guillaume Chanois, he's interested also in the theory of pleural porosity, which could explain why sometimes we have a patient with a large volume pneumothorax and unruptured bullae identified at the time of surgery. But we do find that sometimes if we resect these lesions there and surgically remove those, that the pneumothorax does resolve. But that's another interesting point, I guess, for further research.
Great, thank you. So could you outline what you did in your study and what you found, please?
Yes, of course. So this was a multicenter retrospective study, and it was originally designed in conjunction with the AVSTS, so the Association of Veterinary Soft Tissue Surgeons Research Cooperative. And the aim of our research was to describe the clinical characteristics, but also the recurrence rate of spontaneous pneumothorax secondary to pulmonary blebs and bullae in dogs following surgical management. We also wanted to explore potential risk factors for recurrence, and we also wanted to look at those dogs that did develop recurrence and see how they did and what their outcome was. So when we looked at the current literature that's available on this topic, we found that there was quite a small number of available studies. And a lot of those studies had cases of primary and secondary spontaneous pneumothorax. So a lot of those looked at cases where they had an underlying neoplastic disease or pneumonia. And so there were very few that focused solely just on pulmonary blebs and bullae. And of those cases that did, or of those studies that did, they found there was quite a low number of those in that study. So our aims were basically to investigate the surgical management of these cases purely pulmonary blebs and bullae, but on a really large cohort of dogs. So we essentially invited centres from around the world to contribute their cases, and we ended up with a total of 11 referral hospitals from America, Australia and Europe. And they all sent us their data that we entered into our database. And then we essentially had to go through and review every case painstakingly to make sure that they were suitable for our inclusion criteria. And so our inclusion criteria was dogs that presented with spontaneous pneumothorax, that had undergone surgical management and were diagnosed with pulmonary blebs or bullae at the time of surgery or based on histopathology. And then once we had all of that information, we then looked for cases that we would exclude, which would be any cases of secondary spontaneous pneumothorax, where we'd found evidence of neoplasia or pneumonia at the time of surgery or on the histopathology. And then when we had all of that data, we could then analyse that descriptively. And so we had 111 dogs, and what we found is that our findings based on the signalment and clinical presentation echoed that of previous studies. So we found that the majority of these dogs were middle-aged when they presented. So I think our median time to presentation was 6 years and 8 months. We also found that these dogs tended to be a large breed. So our most common breeds that were presented were Labradors and Siberian Huskies. And as you'd expect, most of these dogs presented with dyspnea or tachypnea, consistent with the pneumothorax. And then we looked at the different diagnostic techniques. So we looked at different imaging modalities that had been used, and we found that the majority of cases had received a CT scan prior to surgery. So I think it was up to 81% of dogs had a CT scan. What was quite interesting was that despite this wide use of advanced imaging, majority of the surgeons went on to perform a median stenotomy. So I think even if a lesion was identified and localized, they still went on to explore the entire thoracic cavity. And of those cases, there were a smaller number of cases that had a lateral thoracotomy and an even smaller number of cases that had a thoracoscopic procedure. I think there's only 4 out of 111 that had a thoracoscopic procedure. And for those ones, 3 out of 4 of those needed to be converted to a median stenotomy due to an inability to identify a lesion. So I thought these were all like quite interesting findings with such, a big cohort of data. And then when we also looked at the surgery itself, so we looked at the different lung lobectomy techniques. So majority of people used stapling devices, others used sutures, and there were a couple of reports of using a vessel sealing device, which I think has also recently been reported in the literature, and these were for more sort of peripheral lesions in the lung lobe. And then once we had all of that information and had reported that, we then looked at our second part of our question, which is, are there any risk factors for recurrence? What is the recurrence rate? And what happens to those dogs afterwards? So in order to answer that question, we had to refine our data a little bit more. And so we looked at dogs that only had a minimum of had to have more than 4 weeks follow-up, because we looked at past studies and looked at when it looked like it was most likely that dogs would recur, and most of those tended to happen in the first 4 weeks. So that was our cut-off point. And then all of the dogs that had more than 4 weeks follow-up were then included in our inferential statistical analysis, and so that was 99 dogs that we had to look at our risk factors. And basically we had a follow-up of 850 days. And we identified that there was a risk of recurrence in 14.1% of those. And I think, again, that's comparable with the previous reports, which is from 0 to 25% in the other studies that are available. But it's also significantly lower than that of medically managed cases with spontaneous pneumothorax. I think it's important to note that that we had very few instances of recurrence. And so We avoided testing lots of risk factors, which in turn could have made our overall analysis quite unreliable. So we chose only to test the risk factors that were part of our original pre-study hypothesis. And so the risk factors that we analysed were the number of blebs and bullae that were identified at surgery, the presence of any unoperated lesions, the surgical approach, the weight and giant breeds. And what we found is that there was no increased risk for dogs with more lesions, unoperated lesions, or dogs undergoing different surgical approaches. But what we did find is that there was a possible increased risk for dogs with increasing weight and giant breed dogs.
Perfect. So yeah, in fact, I wanted to follow up a little bit on these increased risk of recurrence for giant breed dogs. There were kind of a small number of patients in this category from what I could see. And do you guys have any hypotheses of why these recurrence could be higher in these breeds?
Yeah, I think we can offer some theories as to why we think that might be the case and why there might be a slightly increased risk for giant breed or larger dogs. I think one explanation is that there is possibly an increased challenge that comes with examining the entire thoracic cavity of a larger dog, a giant breed dog, or a dog with a sort of deep chest. And so one of the questions that myself and some of the other authors had was whether these cases of recurrence are truly cases of recurrence where a new bleb or bullae has formed and then ruptured, or whether these reflect missed lesions. I think this is always going to be a really difficult question to answer, because it's hard to know, isn't it, whether you've missed a lesion or not. Sometimes you can look at the time at which they recurred and say, well, if it recurred a few days after the surgery, is that more likely to be a missed lesion? And if it occurred 1,000 days after surgery, then is that a new bullae that's ruptured? But again, it's always really hard to say. And then another sort of theory, or just an interesting point, was that when we looked at the human literature, we found that human patients that were diagnosed with primary spontaneous pneumothorax tended to be taller than control patients. And so it suggested that taller individuals subject the alveoli at the lung apices to significantly greater forces due to this gradient of negative pleural pressure that increases from like the lung base to the lung apex. And so this might be applicable to giant breed dogs or dogs with deep chest conformation. But again, I think more information and more investigations are required. But again, I think it's really important to note something that we stress throughout the paper is that in all of these analyses, both univariable and multivariable, they included very wide confidence intervals, and that's in keeping with the low statistical power resulting from the small number of recurrences. But I think, again, important to remember that further data is required to confirm these exploratory findings.
Perfect. Yeah, I think it's very interesting, the kind of human medical occurrence too. One of the reasons why I think your study was awarded this award is also because it was a multicenter study and very thorough analysis. But I wanted to focus a little bit more on the multicenter part of it. And this can be, just what were kind of your feelings about setting up this multicenter study, and what are the challenges that other researchers are going to find when they're setting a multicenter study like this one? We often try to do this more and more also in our practice, and we find differential compliance, and we just would like some suggestion from you, since you guys were able to pull this off very nicely.
Yeah, no, it was obviously these multi-center studies are always beneficial because you can just increase your case numbers massively, and then you can do sort of more statistical analysis, which was our aim. I think that the AVSTS Research Cooperative were very helpful in helping us recruit centres from, again, all over the world. So we had that to fall back on. The what we thought was really important was making a really good accrual form. So basically a data spreadsheet with exactly the data that we needed. So we'd already drawn up our hypotheses, we knew what we would be testing for. So having that ready and in a format that everybody could conform to, that was really, really key for when we came to that crucial data analysis. One little tip I would say is always keep your dates in either American or English order, because that confused the hell out of me a few times. So but yeah, so a really good spreadsheet was really helpful. And then the centres that we had, I think they were so proactive and filled out the form so carefully. The data, the quality of it was excellent. So again, that's a special mention to all of the authors that contributed in that way. But yeah, it was challenging, and there was a lot of data, and I think we had to be extremely thorough about what our inclusion and exclusion criteria would be to make sure that the quality of that would be good enough for the statistical analysis. Then I think we need to obviously have a special mention to Dr. Nick Jeffrey, who was instrumental in our statistical interpretation as well of the data, and was really committed to testing only for the pre-study hypotheses and not over-analysing other risk factors. You know, we didn't want to have any underpowered test results, but yeah, it was a challenge, but it was definitely worth it once we got all of the data together.
Thank you. So a common limitation of retrospective studies is the lack of standardization with regards to diagnosis and treatment, and presumably this may have been, increased with having that multi-institutional study. And I just wondered what impact, if any, do you think that the lack of standardization may have had on the results of your study?
Yeah, so I think, as I previously mentioned, we had really strict criteria for the interpretation of the results. So I would hope that the lack of standardization for the diagnosis and treatment would hopefully have had a limited effect on our findings. I think probably one of the main limitations of a study of any retrospective nature is the data acquisition, because the data that we can retrieve is only ever as good as the data that was recorded at the time of the treatment. But again, our all of the centres that contributed data were really thorough about that and really good at getting the follow-up as well. So I hope that the data that we got was the best quality that we could do. But obviously, as always, further prospective and standardised studies would be ideal, but often it's challenging to do so.
Well, thank you both so much for giving up your time today to discuss this paper, and thank you for listening. The full version of the paper can be found in the July 2020 issue of the Journal of Small Animal Practice. A link can be found in the comments below the recording.